Welcome, welcome. This is your last, is this your last lecture for semester?
I think so.
Yes. So another semester down, 8 months you are actually going to be unleashed on the world with your own patients, like actual people. Like they're going to pay you. Yeah. Not to fix them, because you can't fix anyone. We'll go through that a lot today. As an EP, it's not your job to fix any of your clients or your patients. It's your job to guide them, facilitate their recovery, give them the tools to get better. Never set yourself up for saying, I'm going to fix your problem, I'm going to be the one that's going to take your pain away or reduce your HbA1c by a couple of percentage points. You just want to be there to guide them. Because if it doesn't go so well and it doesn't change, they're going to blame who? Themselves or
You.
yeah. Yeah. You're like, well, this didn't work. And you're like, well, did you actually do these things? How onto it were you? And that's a really big thing with MUSC rehab as well. You can't fix, don't ever set yourself up with that. Alright, so today we are going through a couple of the really typical presentations that you will probably see, particularly if you're working in general populations, which most of you probably will end up doing. You might end up seeing some kind of sub-elite and recreational athletes, almost certainly. A lot of you will probably end up going into general population stuff, a lot of everyday musculoskeletal injury, rehab, workers' compensation. So we're going to go through a couple of really common ones. We're going to recognise the typical clinical signs and symptoms. You're going to learn some assessment techniques. You will have to go away and practice these. So we'll go through them today, but your learning and your comprehension and your recall of these tests is going to be based on how much practice that you actually do. So heaps and heaps of practice with the assessment techniques so that it just becomes routine. You're like, I've got a shoulder. Okay, these are the ones that I do, particularly when you first start, because you'll see your patient and they'll say, I've got shoulder pain, and you'll probably just go blank. So I want you to be able to recall the typical kind of shoulder tests that you can use for each patient, and then as you get more confident, you can add to that. Then we're going to go through a little bit of a staged rehab kind of protocol for each. I'm not saying that I'm giving you recipes, because there really are no recipes for rehabbing different injuries. You'll each learn your own kind of tried and true exercises and methods as you start to become more experienced as clinicians. But there'll be a few here that'll just get you going, particularly with the tendinopathy stuff. So we're going to go through plantar fasciopathy, weak and painful shoulder, which is predominantly the shoulder type and presentation that you'll see. You're probably not going to see the traumatic ones. If you do refer on, we shouldn't be doing acute stuff. You may see a few frozen shoulders, but really, by and large, it's going to be weak and painful shoulder. Chronic neck pain is a really big one, particularly if you go into workers' compensation. A huge one, and I know you guys haven't gone over that yet, so hopefully today we can give you a little bit of a base. Lateral epicondylalgia. Does anyone know what that is? Don't look at your notes.
Pain.
Yep, so algia, pain, yep. Whereabouts?
Lateral epicondyle, one would think.
Yes, exactly. Exactly. So elbow pain. Yep, so lateral epicondyle. So elbow pain, tendinopathy, really common one there for occupational overuse, whether it be in a sedentary office-based type population or manual labour. So in Sparkies, this is a really big one, carpenters. So where you're doing that repetitive elbow flexion extension and pronation supination, particularly when you're on the tools. And glute med tendinopathy is another really big one you'll see. Does anyone know why we're kind of seeing a lot more tendinopathies over the years? What are some of the risk factors? What do you know about tendinopathy now? Who's at risk of tendinopathy? What are some of your risk factors? Don't look at your notes.
If with tendinitis, you don't do rehabilitation to realign the tendon properly?
Kind of. We don't call it tendonitis anymore. That's a really big one. I don't want any of you calling tendinopathy tendonitis because it's not an inflammatory condition. So tendonitis, tendinosis, dead in the water. We don't call it that anymore. So we know now from the research that with tendon pain, it's not inflammatory. There's a whole other cascade of events that are happening in that tissue and within the central nervous system and your peripheral nervous system that are setting that person up for ongoing pain. But it's not inflammation. It might be inflammation at the very start, but as that person goes on, it doesn't become about inflammation. So risk factors for tendinopathy, the reason that we're seeing more of it is because being overweight and obese is a really big risk factor. And what's happened to our rate of overweight and obesity in this country? It's not great. It's not amazing. Like more than half of us are overweight, like 20% of us are obese. So you have a lot of inflammation generally systemically when you are in that weight category, and tendons don't really like that systemic inflammation. So that's a really big one. So it kind of explains a lot why we're getting more and more tendinopathy presentations. So these are the ones that we're going to be going through today. We're going to start off with plantar fasciopathy. Used to be called plantar what?
Fasciitis.
Yep. But it's not an itis anymore because it's not an inflammatory condition. Has anyone known anyone who's had it?
Me.
How'd you find it? How long did it take?
Oh, it's 6 months, which I think is pretty good.
Damn good, absolutely. So with plantar fasciopathy, often patients still have symptoms up to 2 years. Yep. How did yours present?
Stone bruise under the heel is what it felt like at first,
Yeah.
and then it just got worse and worse, and then
Yeah.
I blew it up one day running angry,
Yeah.
and just it exploded, and could barely walk for, and I thought I've got to do something about this.
Yeah.
So off to the physio I went.
Yep.
Because we didn't have any EPs in
Yep.
town.
Yep. So EPs can manage plantar fasciopathy really, really well. So plantar fasciopathy doesn't really respond well to cortisone. There is some evidence that exercise and manual therapy can have good outcomes, but really, with any tendon issue, it's loading. This is where you guys really come into it. The thing that gets tendons better is exercise. Hands down, it is the most efficacious treatment out there. So this is where we come into it. With plantar fasciopathy as well, it's all about load management, as you well know. You can't go from a really painful heel with plantar fasciopathy and just go, oh yeah, I can just push through it, it's fine, I'll go for a walk and then I'll progress into my running. Nah, often you have to go through a really kind of a significant deloading and then a progressive loading phase. And you know what we used to do for it was just stretch it. Tendons hate being stretched. Do not stretch tendons, particularly a tendon that's painful. So if you go into aggressive stretches, you're going to make your patient worse, and that's for any tendinopathy. Do not stretch. What you can do if they need some release work is show them how to use the spiky ball and the roller through the muscle belly, but not over that tendon, and do not stretch them. So don't stretch the plantar fascia. They might be tight elsewhere, like through their Achilles and that type of stuff, and their gastrocs and soleus. You can stretch those, and their hammies, go for it, but not the tendon. So, symptoms, mainly at the heel. So, high proportion, like 50%, is at the heel. And then you might get these other presentations running through the arc. Often you'll get co-presentation of heel pain and pain through that kind of midsection, through that medial arch region of the foot. The things that you can recognise, if your patient says, oh God, when I first get out of bed and I take a few steps, oh, it's agony. You're already thinking, aha, this sounds familiar to me. So it's those first few steps in the morning, and then it sort of gets better after 10 minutes. You're like, oh yeah, starting to warm up, have a shower, have my brekkie, starting to feel pretty good. If that patient's been sitting down for ages, so if they've got a sedentary job and they're an office worker and they say, oh, you know, I'm sitting at my computer for hours and then I get up and it's those first few steps that are really painful and then I take a couple more and it's okay, that's another classic sign. Pain increases towards the end of the day if you've been on your feet all day. So they might say, oh, yeah, I'm fine during the week when I'm at work, it's okay, and then on the weekend, you know, we go to the farmer's market and then, you know, and then I do some gardening and I do some cooking that day, and at the end of that day, it's really painful. So that's that overload potentially on the weekends. So you kind of want, if you start to hear these things, your patients are telling you these things, you're already thinking, all right, I'm putting together a little bit of a clinical picture. This sounds familiar to me. This is sounding a little bit like plantar fasciopathy. So level of pain, and like I said, the location of the pain can vary, and it's usually in an older population, usually say kind of 35 and older. It's not inflammatory. Do not tell your patient, oh, you've got an inflamed plantar fascia. Never say that to your patient. Because it's not inflammatory. So what we know is we have a few degenerative changes. You never say degenerative changes to your patient either. Don't mention the word degenerative, because to the average layperson, degenerative is like, oh my God, I'm falling apart, it's all over, I'm fragile, I'm weak, you know, things are going to be bone on bone. Never use the term degenerative. So you might just say you've got some changes within the collagen there, and we know that exercise can change that collagen type back to a healthy type. That's the type of stuff you would say. You just need to deload it a bit and then we can progressively load it up and get you stronger. So we know that initially you get an increase in ground substance proteins. And so that's like your proteoglycans and your glycosamines, and they draw water into the tissue. And that's when you'll get a thickening of the tissue. So this person might go and have a scan and the ultrasound might come up of, yeah, thickening of the plantar fascia. Again, you don't really need to go into that with your patient. And often a scan, if we scanned heaps of people that didn't have pain and we scanned their plantar fascia, they'd have evidence of degenerative changes as well. I mean, it's the same with any of your back pain stuff, your MRI scans. The rate of pathology found in pain-free people is significant. Like it's like up around 90% in people aged over 40 years of age, degenerative changes in their spine. But they've got no pain. So really, a scan is not going to tell you the whole picture. It might just add to your clinical kind of knowledge and your picture of really what's going on with that patient. The other thing with scans is you might go through your rehab, and if that person, say at week 1 when they came to see you, had a scan and it showed changes on the ultrasound, you might do a 3-month intervention with that patient and they get rescanned at the end of 3 months and they're way better. Like their pain is awesome, their pain's really low, their function's really high, they're loving it, and they get the scan done and that scan would show nothing, that no changes, it'd still say, oh, you've got a shitty tendon. So really, the scan is not everything. It's a really low predictive value, that initial scan, and you can say that to your patient. Okay. The other thing that we get is increased vascularity and neurogenesis, so they think that's why they can become quite painful as well. So you get little infiltration of more blood vessels, more vascularity through those structures. And same with your neural tissue as well. It's not inflammatory, that's the main thing I want to get through to you guys. So risk factors we've talked about. So the most common patient that I see that comes in with plantar fasciopathy and heel pain, and I see a lot of it, kind of like really you're over 45s and often they're overweight. Sometimes you'll get a really keen bean that comes in that hasn't done exercise for 10 years and they're like, oh, I just started walking up Mount Isa every day. I'm onto this. Feeling great, but I've got this heel pain or I've got some Achilles pain. We're not going through Achilles tendinopathy today, but it's another really common one. And you'll see it with your middle-aged cohort that have suddenly gone from no exercise to going, okay, I've watched, you know, The Biggest Loser, or I've watched the Michael Mosley program where they say to do the HIIT training, and I've started running, and I've started doing sprints. And they've come from nothing, and they've gone to straight into doing sprints. So that's kind of the most likely cohort that you'll see. So it's a huge increase in risk if you are obese. Nearly, like, close to 6 times the risk. That's 600% more likely. It's massive. Work-related weight bearing, so people who are spending a lot of time on their feet during the day, that's a really hard one. Like, I've had to rehab gardeners and horticulturalists that have got plantar fasciopathy, and it's hard because they are on their feet all day. And that's where you need to have a really good relationship with their rehab provider and get a change of duties, that type of stuff. Because once you've got an irritable tendon, and you keep loading it, it's hard, they just won't settle down. They'll just keep coming up, nothing's changed, nothing's changed, nothing's changed. Unaccustomed load, that's your patient that suddenly decided to walk up Mount Ainslie every day. Not great cushioning, that's your patient that might have gone, oh yeah, minimalist shoes, all about it. And they've come from like Brooks Beasts and they've gone into Vibram 5 fingers. That's an issue. I've seen it. Low estrogen in women, so think postmenopausal. So if you've got a female that is late 40s, early 50s, she's overweight and she's just started to load up, you've got a perfect storm there. And not just through her feet, but all through her Achilles, her glute med tendon. So that's where you have to have a conversation about these risk factors and about the loading profile, and that can be part of your exercise intervention. Pretty poor ankle dorsiflexion, less than 10 degrees. That's pretty tight. It's not amazing. So you guys will know knee to wall, you know how to do that. Hopefully we'll go back through that in the tubes. So poor ankle range, tight hammies as well has been found to be another risk factor. Reduced extension range through your big toe. So if you've got a really stiff MTP of that big toe and that patient can't go into extension, that's a real problem because that affects the mechanics of the plantar fascia when that person is walking and running. So there's a test that we use for that called the JACS test that you can assess to look at how extensible and how mobile that joint is in weight bearing in extension. Foot pronation or high arches, actually not shown to be a risk factor, but once that person does have pain, that then probably becomes an issue. So they found that it's not actually a major issue and a risk factor leading in, but if you've got pain and your biomechanics are changing, that's probably potentiating the issue. But it's not a risk factor in and of itself. So stop talking about pronation to your patients. Unless in function they've got really poor arch control, and I'll show you how to assess that. Okay, so assessments. Which ones of these are familiar? Most of them?
Most of them except JACS test, I think.
Yep, awesome. Let's go through the JACS test. Palpation. Where would you sit the patient? How would you position yourself? How would you do it? What do you reckon? I usually go with them sitting over the edge of the bed. feet down, and you can just start to palpate through the heel and then palpate through that medial arch. And you might really have to get in there. Don't be shy. And you're just noting in your clinical notes, you would say tender on palpation or pain on palpation. You might go medial heel, lateral heel. Just note where that pain was. So it's a really important one to try and elicit that pain within that spot. And then you can ask them, is that where you feel your pain when you're walking? Okay, Jack's test. So Nita, while we're all good with you? Yep. Happy with doing it with the centimetre thing and then with an inclinometer?
Well, we haven't used any, I don't think we've used any inclinometer, but that's okay.
Yeah, super easy. We can go through that in the tube. All you're doing is zeroing, you're putting your inclinometer over tibial shaft in neutral and get them to do Nita wall. You zero your inclinometer beforehand and then they do the movement and then you just read off your ankle, essentially. So really, really easy. But usually in a clinic setting, you'll have permanently set up like a little bit of tape with your centimetre stuff there. So it's already there. I usually use the centimetre marker. Okay, Jack's test. Let's do this. Bit like some ads, guys. Sorry.
Another way of assessing subtalar joint flexibility and one similar to the heel raise test is the Jack toe raise test. This takes advantage of the windlass effect of the plantar fascia, just in the same way that heel raise demonstrates windlass effect. In this case, we see the height of Sanders arch. When I corporally straight toe up, we see arch elevates, and the toe drops.
Happy days, we like that.
Arch drops.
See this?
Toe up, arch elevates. This is because of the windlass effect of the plantar fascia.
That's good.
A flexible subtalar joint allows this to happen.
That's the windlass
The
mechanism.
plantar fascia originates on the calcaneus and it ends at the base of the toes. If we dorsiflex the toe, we pull the heel toward the metatarsal, and the so-called windlass effect, the arch elevates. This happens in a flexible subtalar joint foot.
That's a healthy, that's good, we like that. That's what should happen.
Demonstrating subtalar joint flexibility by the same effective mechanism as the heel raise test.
Have you got time to explain this windlass mechanism that
So,
everybody
yeah.
talks about?
So the windlass mechanism is when you extend your MTP of your big toe, so your first MTP, and you would go through that toe extension, it puts a stretch onto the plantar fascia. And then when your foot comes off, it's then contracting. So you're getting some free energy. It's a really important mechanism for the foot. Oh, no, we don't want you to go away. So in a really poor foot, when you went to do that test, and if anyone here in the tute has quite flat feet, you'll find that there's a lot of resistance. And you either can't extend that big toe up, or you extend the big toe up and it's happening, but you're not seeing any pliability or movement through that medial arch. That's a problem. And then we would go in and kind of drill down and go, okay, how good are you through your tibialis posterior? Because that's a really important muscle for medial arch support. And how good are your foot intrinsics? Like, can you actually create a little foot arch, or is that really hard for you? So that's the type of stuff that then you would then go and assess. Okay, all right, we've got a positive Jack's test. I'm not getting much extension, and I'm not getting a whole lot of medial arch lift. That would be a positive test, and then you would start to go, okay, I probably think that this patient probably doesn't have great subtalar control potentially, or they've got really poor arch dynamics, and then you would drill in and start to assess tibialis posterior. So tibialis posterior manual muscle test, have you guys done this one? Where does it run, tib post? generally. Yep.
Down there, isn't it?
Yeah, yep,
And
yep.
it's an
And, yep, it's an inverter, yeah.
Flexor.
Yep,
Plantar flexor.
plantar flexor.
Sorry.
Yep. So it's a plantar flexor and an inverter. So really, really important for your runners particularly, athletes that are doing a lot of high load, and a really common site to get tendinopathy. So if you think about if you've got really poor arch mechanics and you're collapsing in and you've got really crappy glutes as well, what happens over time is because that tib post runs just under that medial malleoli, you start to get some friction of that bone on that tendon, and it does not like it. And tendons don't like to be stretched. And so if you're constantly like that, that's stretching tib post a lot, doesn't love it. So a really common site to get a tendinopathy. So testing for tib post strength, let's do it. To go your break test. So that's concentric, yeah?
Mm-hmm.
Yep. Oh no, she was pushing it there, sorry, other way. And now resist through concentric. I probably wouldn't do eccentric because you're just going to get perineal strength concentrically, really.
Mm.
So manual muscle testing, not the be all and end all. So really manual muscle testing, it's not a great test of strength. You're looking for weakness, really. So what you can do is you can go, okay, I'll do a break test, and then I'm going to do an isometric test, an endurance test. How long can you hold that there for? And you're looking for, are they starting to like fatigue? Are they getting a bit shuddery through there? Are they telling you, oh, that's really hard? If they get a cramp in their arch, that's not a good sign. That means that they're probably quite weak through tib post. So if we know that tib post is a plantar flexor and an inverter, what are you looking for in a heel raise then? What happens if they don't supinate or invert? It's not great, is it? No. So when they go into a heel raise, you should see a little bit of heel inversion. If they don't, you're thinking, okay, tib post, maybe a bit weak. So look at them in a bilateral calf raise, so 2 legs, and then look at them in one. And what you'll often find with plantar fascia stuff is, one, their calf raise, they're really reduced range, like they're getting that far off the ground. And their heel just lifts straight up, you're not getting any nice inversion. But always compare affected side to non-affected side. Look at their non-affected side first, look at them bilaterally. So then you can go, okay, well I'm going to do a little bit of an assessment, how many bilateral calf raises you can do before either pain or fatigue. Note that down in your clinical notes. See how many they can do unilaterally on their non-affected side, and then see the difference between their affected side. And then you can use that for your follow-up to see if they're getting stronger with your intervention. Gait assessment, so you're watching for substitutions. What are the common substitutions for walking? What stuff are you looking for? What might you see? Shout out in just general.
If you've got pain, you're not going to be wanting to bend your forefoot all that much, one would think.
You might not, yeah.
So if it's quite acute, you're sort of cutting short that push phase.
Yep, yep. You might be a bit ginger landing on your heel as well, not wanting to do it. What else? They might do a shuffle, yep. You might just not see a lot of plantar flexion. Just not be happening. You might see other stuff going on. Like there might be a really big Trendelenburg there might be a big shift away from that painful side. So look at them. slow the movement down. One of a really good thing to do is film them. Has anyone downloaded huddle techniques to their phone? Do it. It's a good one. So it's free software. I use it most days in the clinic, and you can film the patient using your phone, ask permission, and you can slow it right down for them. And you can draw angles and stuff. You don't have to get super technical. You can just say, I'm going to slow this down to 1/4 of the speed. Look what happens when you're walking. Look at that. Really good for athlete buy-in as well, if you're doing a run assessment or something. Because you can draw the angles. You can say, look at that hip drop, or look at that knee valgus, or look at that really big shift of your thorax. Really good for getting buy-in, patient buy-in when you're doing an initial assessment. And it's not hard to use. Download it, start using it, film your mates, film your family, get used to using it. It's a really, really good one to use. Single leg squat. So you're looking for, are they going into that arch collapse? All of the normal stuff you're looking at for a gait assessment. There are a lot of internal rotation, adduction of their knee. A big one if they've got really poor foot intrinsics is they're clawing with their foot, particularly when they're balancing on one leg. They'll claw with their toes to try and stabilise themselves, and you'll see it. So if you then ask them to go into an arch lift, and you can ask them to do this by saying, all right, I just want you to gently push your big toe down and out against the resistance of my finger. So you'll be here. And you're saying, I want you to do that, and imagine that there's eggshells underneath your arch, and you're going to lift your arch off. And they'll do it. And often they can only do it for a couple of seconds. They'll fatigue. You'll ask them to then stand on one leg and do that, and they'll really struggle. And they'll claw with their toes to try and stabilise. So really poor foot muscle intrinsics. If that happens, you're thinking, okay, I know this person needs to do a little bit of arch training, essentially. Okay, calf raises we've talked about. A really good questionnaire is foot function index with plantar fasciopathy, so you can give that to your patient at initial assessment, and you can follow up with that after a couple of weeks to see if that's changing as well. Treatment options. So always a combination approach. So you want to educate them about what's going on. You want to talk them through their loading. This is where Fitbits can be really good. So if they're doing 6,000 steps on a weekday and 15 on a weekend, that's an issue. So they might not be aware of that. So you might say, oh, look, it'd be great for you to get a tracker. Let's just get some baseline data. Let's see where you're at. And they can then record their steps during the week and then on the weekend to see if there's a difference. So a really, really good one. And so many people have got them now, and usually they're not resistant to buying one. If finances are an issue, then just a really cheap, like $15 hip, like old school pedometer is fine. So you want to talk to them about their loading, particularly if they are the female or whoever who's doing the Ainsley walk. You might go, okay, let's just pare this back a little bit. Sounds like you want to lose weight and get fit. Maybe let's get you into the pool. Let's find other ways that you can work on your fitness without loading this foot. Maybe let's get you onto the bike. You can hire a bike, yada, yada, yada. So you're starting to go through the options with them. You really want to sow the seed early that this thing is going to take a while to rehab. 3 to 12 months, often up to 2 years. 6 months pretty damn good to get through 6 months. You would say to them here, look, you might still have symptoms after this time, but you'll be dramatically different and we'll get your function up, but you're still saying that you may still have symptoms after this time. So you might want to then devise them a program if we're talking about the managing load, for their walking, for their return to sport. This is where we are really good at coming up with management plans for loading. And this is where getting your baseline data for that patient is pretty vital. If they don't want to use a pedometer or a Fitbit, then you can say, okay, can you just record down for me generally what you've done and time on your feet? So they'll do a little activity diary. They might say, okay, sat all day for work here, did a 10-minute walk at lunch and then a 20-minute walk after work, that type of stuff. And then you can get them to record their pain levels, so you can sort of see, are they coping with this load, yes or no? If they don't want to do the more expensive option, then a handwritten diary is really good. If they're in a lot of pain, they can use frozen drink bottle, do your little massage, your foot roller with it, golf ball, massage through the foot, do not stretch. Taping, if you're trained to tape, if you've done an advanced course in taping, you can tape. But we don't normally learn to tape at uni, so only if you've been trained in this. You can advise them to go and try a little heel pad off the shelf. So you might say go to the chemist or go to Athlete's Foot, get yourself a cushioning heel pad or an off-the-shelf orthotic. If nothing's changing and their foot biomechanics are really not great and their JAPS test is terrible and they've been seeing you for like a month and they're really compliant and nothing's changing, then I'd say a podiatrist referral. You've done all your testing for the length of your other lower limb structures, so you could lengthen those off if they're really tight. You can use PNF stretches, roller massage, static stretches, whatever you want. You're probably going to get more bang for your buck using that and massage rather than static stretches. There's not great evidence with static stretches for increasing tissue length. These guys are probably going to be better off to get a little bit more of a result. So you're going to strengthen foot arch, tib post, hip extensors, hip abductors. This all depends on your assessment. And then their motor control in dynamic movements. One of the really, really good ones for plantar fasciopathy is heavy slow resistance, which we'll practice today. So this is a great study that came out not that long ago, and it was a 3-month intervention, and it was progressive. So it wasn't just doing the same exercises day in, day out for months. So they made sure that they progressed them. They've got that big toe in extension, so they're getting that windlass mechanism. And it's pretty heavy loads. If your patient doesn't have a gym membership, often they won't, you can get them to load stuff up into a backpack, I find is really good, and they can do it at home.
Or you can just push on the doorway, push with your hands on the
Yeah,
doorway
yep,
to load up.
yep. The hard thing with that is the hard thing at home is to get enough load.
True.
Because 12, like you end up going down to 8 RM, that's some decent weight. So, like I said, the tough thing is they don't have a gym membership, is just how they're going to load up enough to get the result. But backpack works well. You could start them off pushing up onto it, or you're getting more ground reaction force, that's good. The main thing is that it is progressive. The other thing here is they're allowed to be a little bit painful. Maybe 3 pain points above resting. And that's okay. And you would educate them about that. It's okay if you feel a little bit niggly during your exercises. But it's got to settle down a couple of hours after. Maybe residual little bit of pain the next day, but not diabolical. So don't be scared of their pain, but you want to come up with a system with them. If you say to them, you are going to expect to have a little bit of pain during these exercises, this is completely normal. This is your body healing itself, this is fine. Are you okay if your pain increases up to 3 pain points above normal while you're doing your exercises? And they'll either say yes or no. And if they're not, they'll say, oh, maybe a 2, and we'll go, okay, done. 2's fine. So this doesn't have to be completely pain-free. Yes?
How do you work out somebody's RM when they're really agitated?
When they're really irritable, exactly. So I would not, if they're really super irritable, I would just be starting them off in isometrics. So I would go, okay, let's calm your pain down first, and we'll start off doing maybe a couple of weeks of isometric holds. So you could go up bilaterally and hold for, like you'd time them, time to getting to 3 out of 10. And say, okay, I want you to do that 3 times a day, a couple of reps. Get their pain down, and then you can start them into this. You're not going to push them straight into this if they're really, really irritable. But isometrics should have a really good pain-reducing effect. So they've found that neurologically, it works on increasing descending inhibition, so less pain. So isometrics for tendinopathy is brilliant. So start them off on that, get them back in a week or two. How'd you go with your isometrics? Yeah, great, pain's right down, okay, good. Let's see if we can start to do some isotonics, and you'd start just with body weight, and then you can build them into this. But not if they're super irritable. Great question. Does that make sense?
Mhm.
Yep. Okay, so this is just a little bit of an example of some of the other stuff that you could do with them. If they were really weak through that arch, you're looking at foot intrinsic stuff. So 10 lots of 10 seconds. Progress them to single leg standing, and then you could progress them doing a lunge with that, then progress to a single leg squat holding that arch, then progress to jumping and landing with a good arch. Go through your normal rehab. Isometric stuff, isotonic load, motor control, plyometric stuff. That's your normal loading protocol. Foot scratching can be good, fast and slow contractions to work on fast twitch and slow twitch fibres. Ankle eversion, that's just going to be your tib post. You can use a weight if they've got a weight at home as well. That's going to be, you can do a heavy, slow resistance. Squatting with calf raise, single leg balance, you name it. Work out their deficit, work out where they fall apart and train it. This is just to give you a little bit of an example of some extra exercises that I might give a patient. But you will know what to give them based on their deficit. So if they're super weak through hip abductors and extensors, train it. Train it in function and train it formally. Okay. Are there any questions on Yes.
Why do they experience pain in the morning? So I've been off their feet. Is
Yeah.
it just the position of the foot during the night?
I think because it's been deloaded, and then you might have some little kind of changes overnight in the contractility of that plantar fascia, and then when you go to stretch it, because it's mechanically sensitive, remember that neovascularization and neogenesis, like the neural neogenesis we talked about. So those little stretch receptors and everything become really sensitive. So if you haven't loaded that tendon overnight and then you load it and you've got more sensitization through those receptors, you're going to get a big pain response. So in any tendinopathy, you've got some sensitization happening. So it doesn't take as much stimulus for that tissue to fire off signals to the brain. Remember, it's not pain. We don't have any pain signals. We only have danger signals that act through chemical receptors, mechanical receptors, stretch receptors, temperature receptors. There's no such thing as pain receptors. So you've got all of those different little receptors in that tissue that haven't been loaded overnight. You load them that first thing, they're sensitized, they send a message to the brain goes, oh, and produces a pain response.
So before they get out of bed, should they do some little movements or something?
They could, yeah, yep, but it's probably that weight-bearing stuff that they're going to need. So they could get up and do, your isometrics would probably be one of the best things to do in the morning. Straight up, do your isometrics, and then off you go, yep. But that's a really, like a good sign that they're progressing well is they've got less pain in the morning and less pain from sitting and standing. They're just, overall, their pain level comes down. Yeah. Cool. All right, the weak and painful shoulder. This is one that you're going to see a lot of. So, the weak and painful shoulder. You're going to see pain and weakness, or often they've got pain, they're not super weak. You've got to drill down into their functional movement and find that provocative movement. But often pain and weakness felt in the shoulder or upper arm on resisted testing or their aggravating activities. They don't have a lot of loss of range. So a frozen shoulder or a really, really stiff shoulder, you're going to have like 50% loss of range, passive and active. But in your weak and painful shoulder, they might have maximum of 30%, so they can still like get to there, they just can't get that end range. A really classic thing that you'll see is a painful arc. So not painful, not painful, 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 not painful. If they've got some ACJ pain, then you'll get it right at the very end. So classic sign is painful arc of abduction. Usually 2 causes. We're not talking about traumatic shoulders here because you're not going to really see them. You're not going to see a dislocation come in after a weekend family footy or something. If you do, refer back to the GP or hospital immediately. Or if you work in a physio practice, refer to the physio. So this is more of your chronic shoulder pain. You're going to see a lot of it. So 2 causes which you are probably not really going to be able to differentiate. Not super well anyway. So we've got subacromial stuff, so rotator cuff stuff, bursa, long-headed bicep, slap tear, ACJ, and then some neural stuff. We are going to learn how to start to put the picture together about differentiating, is it coming from the neck or is it coming from the shoulder? And we'll do our tests in the tube today. But usually, this is what you're going to see, this type of stuff. And it's okay if you can't really go, yes, it's definitely that structure. In fact, you want to avoid telling your patient it's definitely your bursa, or your long-headed bicep, or your supraspinatus. Avoid, we don't have enough sensitivity to test that, but we can get a bit of a clinical picture. Okay, this is probably a cuff issue or something similar. So symptoms, it's usually been around for often a couple of years in some patients that you might see, or a couple of months. They've got pain around their shoulder, either anterior, posterior or lateral, or their upper arm. They might report a sharp pain, a clicking, a catching, a pinching pain through range, or they're just really irritable after they do stuff. Who's had a painful shoulder before? Yep, what's going on? Posterior? Yep. And what are your aggravating activities?
Generally sometimes we'll be at the gym and stuff like
Yeah.
that.
Yep. Gym's a big one.
It was. Such
Yeah.
a
Yep. It'd be good for people to test this guy in the toots to try and work out what's going on. What was your shoulder?
Just overuse, so yeah, the anterior.
Yeah.
And
Yeah.
overhead movements.
Yep. Yep. So pretty classic, I'd say. Yeah. Anyone else or know anyone with shoulder pain? Yeah. Yep, you know people with shoulder pain?
Yeah.
You got it?
Yeah.
Yep, awesome. This will be good. This will be good for testing. So it's one of the most common MUSC issues that you'll see, not just in an athletic population, but as we can see here, in general population. It doesn't have to be related to a particular sport. You'll often see this in people who spend a lot of time doing this all day. Oh, I'm really sore here. It hurts to put my hand behind my back, I can't sleep on it. That type of stuff. So usually pain lifting, pain at the gym, or reaching for things. So overhead, there might be a catch pain. That person might be avoiding reaching overhead because it's painful. Hand behind back can be quite limited, so measuring left to right. So with hand behind back, some of the things that might be an issue, reaching for the seat belt can be a problem in the car. Reaching down to pull pants on can be an issue because it's essentially behind back movement. You might get some lateral arm pain, but is that really a deltoid issue or is it really something in the lateral arm? Very unlikely. It's a pretty common referral pattern from supraspinatus muscle to be down that lateral arm. And a lot of patients say, oh, it's just here, it's here. It really hurts here, there's something wrong here. There's probably nothing wrong there, probably up here. And it moves. Often they'll be like, oh, sometimes it's here, sometimes it's back there. So kind of you're getting this, pain presentation that's moving around a lot. A really classic one for tendinopathy of the rotator cuff and long-headed biceps is lying on the affected side. So if your patient comes in and they're like, oh, I've got this at night, it's the worst, you're probably thinking, yeah, probably a tendinopathy if they can't lie on that side. And even if they're not lying on that side and they're lying on their unaffected side, they're like, oh, if I'm just all crunched over like this, it really hurts. So I feel like I constantly have to open my shoulder up. So any night pain over a tendon area, think tendinopathy. And it's a really reactive tendon. You're probably going to have to help that patient to get their pain down. Night pain, classic sign, tendinopathy. So pretty common pain presentation here. We're not talking about a stiff shoulder, this is just pain and weak, or pain and sort of strong. Okay, special test, what have you guys already learned for the shoulder?
Atlas scratch test,
Yep.
groove test, drop arm test,
Yep,
Hawkins-Kennedy test,
yep,
external rotation leg sign test,
yep, nice.
Keep
There's
going.
one more. I can't remember the last one.
So quite a few, quite a lot.
That's what he's learned.
Yeah, everyone else, oh, shit,
Not so
maybe one of those. There's a lot of tests for the shoulder. There's over 200 of them. And they're called special tests, which is a bit ridiculous because they're not really that special because there's 200 of them. And they can't really tell you a structure. Empty can, what do you think is activating in an empty can? Have you learned supraspinatus, infraspinatus? It's everything here. Your arm is up in abduction, scaption. Everything's going to be active there. You can't, these tests are really not great for ruling in or out of pathology. They're not amazing. They don't have a great amount of sensitivity specificity. So that's why we use test clusters. So you'll be learning, okay, I'm thinking that it might be this structure potentially. I need at least 3 tests to kind of give me some good stats on whether it is or it isn't. You cannot rely on one test to get a clinical picture. And this is where it's hard because you've just got to pretty much work on tests. So, because we're unable to isolate one structure because they don't really have great specificity, negative tests in a cluster can be good for ruling out pathology, positive can be good for ruling in, but you need at least 3. So, based on meta-analyses, there's so much diversity in the performance and the clinical interpretation of these tests that they're not super helpful. So we're not going to use a structural diagnosis. Do not go to your patient, oh, you've got some tendinopathy through your supraspinatus tendon with some potential tendinopathy of your long-headed biceps, some bursal thickening and some irritation. Don't say that. Just say, look, we think there's something going on in around your shoulder girdle. You're strong in some areas, you're weak in some others. You've probably got some tendon changes which we know exercise is going to help with. Don't be afraid to say, I don't know what structure it is. Because really anyone else who's saying, yes, it's definitely this structure, probably not. You just don't really know most of the time. So, terms like shoulder impingement. Imagine if you got told as a person without any knowledge really of anatomy, biomechanics, that you had shoulder impingement. For most people you're going to go, oh my God, every time I move my shoulder I'm pinching it, I'm impinging it. This is a disaster, I'm not going to move my arm. And so you'll find patients that have just completely narrowed in their world because they're not moving around because they've been given this structural diagnosis of you have shoulder impingement. So I would probably stop using that terminology. It's like the whole degenerative thing. So you just want to say, we've got some difference in strength here, let's just get you stronger. Or let's move you back into these movements that you want to be able to do. Is it coming from the neck? So, a really classic sign, if you get a patient that has this deep nagging ache, constant along their medial scap border, potentially coming from the neck, it's a really classic one. If they've got pain in their neck, reduced range, or they've got some neural symptoms down their arm, you're probably thinking, yes, this is probably coming from the neck. So there's some assessments that we can do to get a bit of a clinical picture whether it is coming from the neck. And if it is, you could start to do some exercise treatment with that. If it's not changing, then you can refer to physio, refer back to your GP. So Sperling's test. we're essentially just compressing the foramen. Yep, you'll elicit symptoms if they've got it. Do not be scared of it. You're not going to, yeah, they'll get a pain response, but that's fine. That's what you're looking for essentially. So you're going into extension, lateral flexion, and you're just applying a gentle axial compression down through the cranium. Do they get their arm symptoms? Yes or no? It's a positive test if they do. Upper limb tension test we're not going to go through today. Hopefully that's another tube where we do all of the neural testing. But you're essentially looking for a positive response in that distal arm along that dermatome. Cervical distraction test. So you're opening up that joint space. So that should decrease your patient's symptoms. And cervical rotation. So if they got less than 60, like they're reduced like by about 50 to 60% in their cervical rotation. So if all of these are positive, you're probably thinking, yeah, it's probably coming from the neck. We'll go through these in your tube. You can have a little bit of a play around with them. But with a radiculopathy, it's pretty obvious, right? Like if they've got arm pain and pins and needles, numbness, maybe even a loss of strength there, that's going to be coming from the neck. So your clinical signs, you probably already have there. So we'll go through those later on today. Objective assessment for the shoulder, you're looking at your active range and passive range. If there's a loss of more than 50%, it's a stiff shoulder. We're not going through that today, but that's a problem. So you're probably looking at a frozen shoulder if you've got both an active and a passive range and your patient can only get to here, particularly if their external rotation is there. You're probably not going to see a lot of frozen shoulder though. It's really obvious if you do, and they'll have a lot of pain, particularly initially, like unrelenting pain for frozen shoulder. You want to look at your total range in internal, external rotation. Have you guys done this one? Yeah, so you're lying supine, you can get your total range. That's a really nice one to look at. There shouldn't be more than really a 10 to 20 degree difference between left and right. You can also, in this position, put your patient prone and you can measure their isometric internal rotation, external rotation strength. If you've got a handheld dynamometer, even better. It's awesome to get numbers, really, really good. Otherwise, you're just testing for a weakness, left versus right, internal versus external, they should be fairly similar. So manual muscle test you guys will all be good with. I would then assess, you really want to look at their painful movement. So say, okay, what are you having problems with? Show me that movement and can they elicit it? And you might need to put a weight in their hand or do something, or you might need to get them doing it fast. They might go really slow and go, no, it's fine, it's fine, it's fine. But then if they have to do that movement with speed, then that's a problem. So you've got to find their functional movement, that's an issue. Because you want to keep retesting that as you go through your intervention. Push-pull, so you can look at wall push-up, knee push-up, whatever you need to do. Prone positions for scap strength is really awesome. So look at your T position, look at your Y position. That might be painful for someone. You can apply pressure to that. So you're really kind of drilling down, where is this person weak? Do they have a loss of range? And what functional movement are they lacking? And you'll pull that all into your notes so that you know exactly when you come to retest them what you've done. So for a painful shoulder movement, it might take a lot of loading. So in the case of a gym injury, it might take a really heavy bench press to bring that pain on. You might have to take your patient to the gym and do a bench press. Or you might have to do a heavy, like 15 kilo shoulder press or something to find it. So keep hunting it until you get it. But usually, if a patient comes in irritable, it's not going to be hard to find. You're going to get it in your first few tests. One that I always want you to do is manual muscle test here for external rotation, manual muscle test here for internal rotation. Take them up to 90 degrees, do it there, not if they're irritable. So for some patients you might have to really dig around, for others it doesn't take much to find it. So tendinopathy, signs and symptoms for any tendinopathy. Remember we talked about pain at night's a really big one, can't lie on the affected side. pain with reaching, hand behind back, repetitive shoulder movements, particularly lifting. So we've